really busy and committed with your jobs, homeschooling, caring, whatever it is you're up to right this minute. So welcome to this event, which we're calling Prescribing in a Pandemic. Thanks very much to North Staffordshire Combined NHS Trust, Healthcare NHS Trust, for supporting and organising this event. In particular, Ann Cox and Claire Talentier. Perhaps if you two could wave and just let people know who you are. Thank you. They've been instrumental in getting this event off the ground and getting you all here today. So my name is Sally Crowe. I'm part of the mental health team and I'm chairing today. So my job is to make sure that you get the most out of this programme in terms of your learning and also sharing, and help keep us to the programme as well. Essentially, this is a day of two halves. First, we have some great speakers, followed by some discussion. Then we break for lunch, and then we reconvene to work in smaller groups on practical pandemic prescribing issues. And we have people in the room today in the Zoom call from the local NHS trusts and partner organisations. Perhaps everybody could just give us a bit of a wave to say hello. Thank you. And we have a much broader audience on social media channels where we're broadcasting this morning event on the Mental Health YouTube channel. This means that everything that you do can be seen and heard on social media. So what it doesn't mean is that the Zoom chat is entirely private to people in this webinar. So if you have any issues with that, drop a message to Andre in the chat and he'll come up with some solutions. Ideally, if you could, it would be great to share your camera, see your face, but we completely understand if you'd rather not to do that. So managing the chat today and managing the much broader communication out there beyond the room is Andre, who many of you know as the mental health. And perhaps if you want to say hello, Andre, and just introduce yourself as the other key person in the team.
Yes, hi Sally. Hi everyone. I'm Andre from the mental health. So I've got a multiple role today. I'm hosting the Zoom, doing some live streaming on YouTube, and alongside Claire from the Trust doing some live tweeting. So we've got two levels of audience, you guys here in the webinar, and then an audience who are watching the morning session and the talks on YouTube. So yeah, great to have you all here.
Thank you, Andre. So we're working around introductions, and I can see that Joseph has actually put in the chat something about himself, and I would encourage all the participants in the webinar to do that this morning, just so that we can get a sense of who's in the room, what you do and what your interests are. We'll obviously introduce the speakers as they come up to their presentation. So thanks everyone for putting introductions in the chat. So before I introduce our wonderful speakers, I just wanted to highlight some ways that you can take part in this session, both in the room and beyond the room. So whilst the speakers are presenting, we ask you to mute your microphone to avoid any background noise. If you're not sure how to do that, there's two ways, one at the bottom of your Zoom screen, or you can hover over your name in the participants list. When each speaker has made their presentation, we'll pause and take questions and comments specific to their presentation. And the best way to manage that, because we've got quite a few people in the room, is if you raise your hand in the participants section. There's a little option for you to raise your hand. There's also something at the bottom of your screen which will allow you to do that as well. It's called reactions. If you're new to this, you can do it in there as well. You can go into reactions and click on the hand, and then Andre and I will keep an eye on the participants list to see who wants to ask the speaker a question. If you're outside the room, if you're watching this and following this on social media through YouTube, through Twitter, please do also put your questions and comments, and you can do that, and Andre will pick up those and will bring those into the room for our speakers to respond to. So there's several ways you can contribute this morning. Okay, I think that's all the domestics and the housekeeping done. I can see that people are beginning to put their introductions into the chat. Thank you, Claire. Thanks, Jackie and Kath and Mike. Keep doing that so we can get a feel for who you are and what you do. Obviously, later on today, we'll get to know each other much better as we work in smaller groups. So I think with all the housekeeping done, let's hear from our first speaker, Mark. We're calling him Mark the Medic today because we've got two Marks in our panel of 3 speakers. So it's our way of separating them a little bit, and Mark's happy for us to use that. Mark is a dual-trained child and adolescent intellectual disability psychiatrist with an interest in autism spectrum disorder, and he works at the Tees, ESC and Weir Valleys NHS Foundation Trust, where he's also Chief Clinical Information Officer. Mark's got lots of hats. He's chair of the Child and Adolescent Intellectual Disability Psychiatry Network, and also on executives at the Royal College of Psychiatry. He's director for CBD and training at the Association for Child and Adolescent Mental Health, and has worked with all the big organisations in the NHS within his clinical fields. He's a keen educator and he's lectured internationally. So thanks, Mark, for making time for us today. He's also authored chapters in textbooks. And he also does stuff for Mind and Disability Matters. So he's a busy guy. And we'll put his Twitter handle in the chat function because you can find Mark on Twitter. All our speakers are on Twitter this morning. So do please go and follow them and find out more about what they do. So Mark, are you ready to share your screen? And then we'll hear your presentation, which is called Prescribing in Young People. So over to you, Mark.
Okay, can I just confirm that the screen is sharing?
It is. Thank you very much, Mark.
Brilliant. Okay, thank you. Then today, the sound keeps dipping in and out, so I hope that you can hear me. Sally, please wave if there's a problem you need me to stop because of sound issues. So I'll be presenting on prescribing in CAMHS and LD-CAMHS or ID-CAMHS during the COVID-19 pandemic. And today's a particularly good example of that because I'm currently snowed in. So I am writing prescriptions from home, had to find some stamps, making phone calls and other things rather than going directly into my base. So the aim of my talk is I'm going to give an overview very quickly of the sorts of medications, the indications, types and monitoring that we do within CAMHS. I'm going to cover the positives that I've seen during the pandemic, as well as the challenges that have been posed by the pandemic, and then go briefly over the adaptations that have been made to prescribing practices during the pandemic and some of my own clinical reflections, then on to questions. So prescribing in CAMHS or LD-CAMHS, we cover a variety of conditions, and they're the usual ones within mental health. So we cover psychosis, mood disorders, anxiety disorders, ADHD, so anger, hyperarousal and behavior that challenges others, sleep, and also tics, depending on your service setup. We use a whole variety of medications for those indications. So we have access to the antipsychotics, mood stabilizers, antidepressants, anxiolytics, so medications for anxiety, hypnotics, medications for sleep, sedatives, and stimulants and other ADHD medications. And for some rare CAMHS medics out there, they might also use some of the anti-epileptics as well, if they're in specialist services. Now, when we're prescribing a medication, there's various points that we have to do monitoring. First of all, we need to do pre-prescribing checks. That's taking a history, some observations, and that might also include physical examinations and tests. Once we've started a medication, we then monitor effect. So we ask more history, we do observations, and then we also might monitor side effects. So take more history, do some observations, and we might need to do further examinations or tests. The sorts of examinations and tests that we do are physically, we might check somebody's heart and their cardiovascular system and their neurological systems, particularly, though we may look at other systems within the body as well. Particular tests that we do within CAMHS are ECGs for checking out heart, blood pressure, pulse, height and weight, and also blood tests for certain medications. So, on to the positives of the pandemic. I've managed to fit this, funnily enough, into one slide. So, We've had less face-to-face, which means that children have also had less face-to-face with bullies within their schools. So less physical and mental bullying occurring face-to-face. I've seen differences in stress levels with regards to academia. So if you're not in school, you don't have the pressures of being in school. Online teaching might give you a bit more of a distance from some of those stresses. There's no detentions, no suspensions, no sanctions being placed upon you by your teachers for behaviours. Fewer transitions within the school day or to and from school. And of course, last year we had no exams. So that certainly may help those who have exam-related stress. We've not been going out or interacting with others particularly. So if you have a social anxiety or an agoraphobia, actually those pressures have been reduced. We've had a major avoidance of germs as a society. People are encouraged to hand wash and use sanitizer. If you have obsessive compulsive disorder with a contamination fear or germ phobias, you might have actually been doing better during the pandemic, potentially because you're able to wash your hands and use sanitizer more often and it's fully sanctioned. There have also been virtual contacts rather than face-to-face, and this might be more comfortable for some, particularly those who don't like traveling or don't like genuine face-to-face, eye-to-eye contact. And we see some of that within the children with autism, for instance. Now, on to the negatives, of which there have been many during the pandemic. So I've tried to divide these up into different types, and they don't perfectly fit under these titles, but I have tried. So the first of these is about people. So patient, family, and carers in particular. So there have been multiple changes during the mental states during the lockdown. Anxiety, mood, psychosis, self-esteem, anger, and challenging behaviours have all escalated in many, many children. We've had the addition of COVID anxiety specific to the COVID pandemic. And we've also seen lots and lots of changes in routine, which has been very difficult for those that really need routine, such as children with learning disabilities or intellectual disabilities or autism. There's been social isolation from your peers and friends, and lots of mixed messages and confusion with regards to, can you isolate, can't you isolate, are you in a bubble, aren't you in a bubble, where can you go, how far can you exercise, what are the current rules this week with regards to the pandemic. A lot of those have settled down, but at the start that was very anxiety provoking. And of course there have been bereavements due to either the pandemic or bereavements in general, where you've not been able to go to funerals and things like that. Families have also all been locked in together. So there's been no respite. So if you've got a child with challenging behavior, say with learning disability or autism, or has ADHD and is constantly on the go, those parents haven't had the school days to have a bit of headspace for themselves. Also, they've not had overnight respite and things like that from social care in a lot of cases. There's been uncertainty for people around exam results, school closures and lockdowns. And there's been reduced access to social support, such as respite, schools and activities. And for some families who've been shielding either themselves, the patients, or their household members, this has limited access to support. Next, for the clinicians and services. So we've had challenges with doing mental state examinations and monitoring risks, effects, and side effects of medications. Doing physical health monitoring generally requires that you're touching somebody or very close. That's been very hard to do with social distancing and wearing PPE and various other things. So monitoring blood pressure, pulse, height, weight, and blood tests has been a challenge to do that safely for our patients. Staff have also been working from home. Today I'm stuck at home, and because of the snow, there are children in my house being homeschooled. And that has posed its own set of difficulties for most families. My wife is not a teacher, and neither am I, but we've been all having to do that. Also, the ability to write or deliver prescriptions has been an issue if you are at a distance from the families that you serve. And today I've been writing prescriptions and they'll be going in the post box this afternoon. We've had limited numbers allowed in buildings, so that has reduced access to staff, but also the number of people that can be in a building, and social distancing has caused issues with access. Some staff have been shielding and isolating, reducing access to service. We've also had reduced multidisciplinary team or multi-agency support across the board around CAMHS to meet the needs of young people. The next set of challenges was to do with processes. So we've had risks of increased medication use during the pandemic because we've had fewer alternatives. But this goes against campaigns such as the Stamp campaign, which is about stopping the over-prescribing of medication and starting appropriate medications within learning disabilities and autism. The problem we've had is if medication isn't increased because the risks are going up or presentations are escalating, we've had risks of placement breakdown, harm to self or others, or risks of admission to hospital. Throughout the pandemic, we've had risks of missing diagnoses, not assessing or treating things. We've also had problems with access to PPE, particularly at the start of the pandemic. Mental health came after the acute trusts, and then child mental health came after the rest of mental health. So if you're in the community, you are last in line to get protection from COVID with regards to face masks, aprons, gloves, etc. And I remember my first set arrived, the aprons had no side strings, so I couldn't tie them. The gloves had been provided were 2 sizes too small. They stopped halfway down my fingers, and we didn't even have the face masks at the start. So there have been lots of challenges around access to PPE. Schools not allowing access to us doing assessments and monitoring has been a problem within the pandemic. We've also had reduced slots available in the buildings because of clean downs and maximum numbers allowed in rooms, which has posed difficulties in terms of getting people into the building, but also making sure they're there safely and the next people coming in are entering into a clean space. So we've had clinical staff cleaning surfaces for entire rooms before they're allowed the next person in. Now, technology. I'm a Chief Clinical Information Officer, as well as a child learning disability psychiatrist. And one of the big winners in all of this has been about video platform use. However, there have been multiple video platforms coming out, Attend Anywhere, Microsoft Teams, Zoom, Accurix, and others. And they're all used by different services, which has posed confusion and difficulties for various families to know which apps to have on their phone or on their tablets, and also how to dial into each type of video conferencing platform. The user experience is different when you're using virtual platforms. We've had issues with connectivity. My internet went down this morning, and digital poverty, access to technical kit, access to data, access to bandwidth. I live in a village, and on a Monday morning when everyone dials on, the bandwidth goes down for the whole village. It's not just my house. And then we have problems with digital literacy, parents and children not knowing how to use some of the technologies that we ask them to use. We also have issues from a technology perspective with the accuracy of self-bought blood pressure and weight machines. We test those in our environments. We have them tested over a year and calibrated. If you buy one from a pharmacy or on the internet, there's no guarantee how accurate it will be and whether it will be tested again. Now, in terms of risks during the pandemic, we've had an increased risk of cyberbullying 24/7, 24 hours a day, 7 days a week. It is relentless. You might have got away from not being in school with those bullies. However, they're now on your case all day long, all night long. There's been increased access if there's an abuser in your house, domestic violence, neglect, physical or sexual abuse by an abuser, with no ability to escape. You may be coerced, and it's quite hard to tell if someone's on the screen with you or on the telephone, whether there's somebody whispering in their ear or pointing things out, and that leads to all sorts of safeguarding issues. There's accuracy of mental state examinations and monitoring, and the possibility to miss subtle signs if you're doing things remotely. It's really hard to tell whether someone's got akathisia when they're on the telephone and their legs are shaking. There's been reduced face-to-face monitoring, so less information is available, both in a quality and a quantity perspective. There's also been some delays to service provision, such as assessment for neurodevelopmental disorders and treatments, because a lot of those systems were stood down during the pandemic. Now, the adaptations that have been used, I hope you can't hear the printing that's happening at the moment. My children are printing out all their homeschooling as we speak, and I will just need to hand it through the door. They were given instructions not to, but they've not listened. So just give me a second. Not helpful. Thank you. Is that we've been using the telephone or more, and that's actually been the biggest winner during the pandemic. We have been doing video conferencing, either one-to-one or with the multi-agency setting. From a face-to-face perspective, we've been having to use PPE, passing on COVID to our patients twice a week. We've also been buying or lending kit to people. Not all systems have been able to do that, but blood pressure and pulse monitoring, height, weight, some systems have been giving away data or tablets to be used by patients so we can access them if they're more vulnerable or have difficulties with access. We have been self-monitoring parameters. So people have been buying their own blood pressure, pulse, height and weight machines, and they've been doing it all themselves. And we've been having to take the risks attached to that. And also we've been doing things like sending prescriptions by post if they weren't controlled drugs, or asking colleagues to write prescriptions for us if you're taking it in turns to be on site. Now, my reflections during this pandemic are there have been various groups. So one group of my patients needed regular pandemic when it first started. Another group did okay at the start, but then needed extra medication at a later point. A third group needed no changes to their medication. Being at home with your parents without any of the other stresses around you has been fantastic. Some children have done really, really well during the pandemic because they wanted to be at home with their parents anyway. One group may have required less medication. However, it's been really difficult to reduce medication during the pandemic because families have been very, very sort of averse to the idea of us reducing medication when it risks escalating other things in their household. And a final group, we've had an increase in the use of as required medications or PRNs with increased numbers of crises and no access to respite. So in summary, CAMHS and LD CAMHS have still continued all through the pandemic, but with lots of differences in service provision. There have been some positives about mental health, but also many, many challenges regarding mental health and service provision. Some creative solutions have been tried and have also been successful. So thank you for listening, and I'm available for questions now.
Thank you, Mark. That was terrific. I think we probably all enjoyed the homeschooling intervention actually in your chat. It sort of feels real life.
In the middle of my chat.
I know, it's okay. We're all good with it. And actually your sound quality was pretty good. So no worries on that front. So we've got two questions to kick off, one from beyond the room, and then I'm going to come to Mark Horowitz, one of our speakers who also had a question for you. And do please put questions in the chat or comments for Mark as we go through. So the first question came from beyond the room, and it says, thanks, Mark the medic. How easy is it to carry on monitoring young people on medication during the pandemic?
It's been a real challenge, though all of my caseload initially got a phone call every single week from me for the first 6 months. That did start to wear a bit thin with families, but we RAG rated, so we red, amber, green rated every single case. But if you're on medication, you automatically went to red, which then put you on weekly review. That has meant that I haven't been to the toilet for the first 6 months or eaten lunch or even walked anywhere. You know, I think my step count went from 11,000 down to 250 steps in a day at one point. So it's been a major challenge, but monitoring medication has been difficult. The main advantage I've got is that a lot of my families I know really, really well. I know which ones I have to send someone to their house to check that they're doing okay. And the others I have been able to do a lot by telephone. Interestingly, I was expecting a lot of families to choose video conferencing, but every single family said they didn't want it. And their primary reason was, I don't need to make sure I've done my hair or get out my pajamas that day. So that was at the start of the pandemic. But monitoring has been a challenge, particularly blood tests, blood pressure, pulse, height and weights, ECGs. The GPs have been fantastic with helping us out because they did have full PPE at the start. But we have generally managed, but it has been a challenge.
Thank you, Mark. Thanks for being so candid about that. Mark Horowitz, I'm going to come to you next. You wanted to ask Mark the medic a question. Do you want to unmute and put your question?
Sure. So you described that a lot of changes that happened during the pandemic that we would never have expected to happen have been good for some kids, not for all kids. You sort of outlined pros and cons. Do you think that after the pandemic is over, which I guess one day it must end, do you think that you would implement some of those changes, changing the way that people attend school or the way that they interact with others, as a way to manage some of your patients' conditions?
Certainly, we've had an experiment of kind for some of the children who have benefited even from not being in school. And obviously, if someone is being homeschooled or being hospital schooled, we do need medical letters to say that's appropriate. And for some of those children, we have now identified the ones where it is absolutely appropriate in those cases when things get too difficult stress-wise. Certainly, we would continue doing some telephone reviews, definitely video conferencing. Families not having to all drive in has been fantastic. And I've not had to leave my desk either. So normally I would spend 50% of my day driving around the community. I do every single one of my reviews in schools, by the way, or someone's house normally. So for me, I would certainly continue with some things, but I can't wait to get back to face-to-face. But yes, there are some aspects where the positives have been very clear.
Yes.
Thank you, Mark. So our next question is from YouTube, Mark. So you've reached beyond the room, which is fantastic. It's from Joanne Kennedy. And she says, I wondered what your experiences were for assessing ADHD without regular school happening. I wonder if you'd like to just respond to that.
Now, that has been very difficult because the school environment produces the structure that we need to be able to see somebody concentrating. And of course, most of our ADHD medications, not all of them, but most of them are only for the school day. So it has been quite difficult, though all of my caseload are under SEND guidance. So they all have education, health and care plans. And those schools have let my team in where they felt it's been really, really essential that we start thinking about medication or other treatments. So some of the schools have let us in. But for those who've not been in school, it has been really difficult to know what we're actually looking at, because I know some children actually manage the school day quite well. They go home and we see all sorts of behaviours, but some of those behaviours are to do with parenting. Some of those behaviours are to do with that they're more comfortable in the home environment, but also we're not seeing at home that need to concentrate and focus in the same way as you would within school. In school, of course, you may have somebody assisting you all the time, helping you get back on task. But it has been really difficult to assess, particularly for ADHD, though we have managed it with a few of my patients and started medications during the pandemic.
Mm-hmm. Okay, thank you, Mark. So we're going to move on to our next speaker. But in the meantime, if any of what Mark has just said in response to questions has just triggered off another thought for you, particularly say around schools and the intersection between schools and learning disability and autism, or any of the things that Mark's talked about, do pop a question or a comment in the chat. And if you're beyond the room, use the YouTube channel and Twitter to pose your questions, because we are going to have a short period of time at the end of the presentations for more questions to our speakers. So I'm just going to tee up Christine Hutchinson now, who's going to talk to us a little bit about prescribing considerations when working with people with learning disability. So Christine, you need to just share your screen with your slides if you would, and unmute yourself while I introduce you. So I'm not sure if it's Christine or Chris, which do you prefer?
Or either is absolutely fine.
Okay. So thank you very much, Chris, for joining us today. And I know you've already had a very busy morning. Chris is a consultant nurse and approved clinician with the Community Learning Disability Services at Lancashire and South Cumbria NHS Foundation Trust. She's functioned as a responsible clinician in both inpatient and community settings since 2014, and has also been a nurse prescriber since 2005. And she's also an independent consultant and expert witness. And Chris is also available on Twitter for interactions, and we'll post her Twitter handle on the chat in a minute. So Chris, I just want to check you're okay to start, because I know you've had a busy morning. Are you feeling okay to start your presentation?
Yeah, absolutely. I mean,
Brilliant.
It's nice to hear and see from Mark, you know, that as you say, the reality of working in the pandemic, you know, this notion of back-to-back meetings and people squeezing things in the minute that they see that you're busy from 11:30. Well, we'll just squeeze something in quickly before you get onto that. And that impact that then has on our ability to balance and manage our own approach to our clinical work, and therefore the impact that has on the people that we are interacting with as part of our clinical work. You know, this kind of pressure that, you know, it's a huge pressure keg we're all working under at the minute, and we really need to kind of get a grip. So I've taken a slightly different approach to Mark in terms of my presentation. I think one of the big things that I've learned during the pandemic is that we are all so busy that sometimes we need some reminders of some of the things that we knew were in place and operational pre-pandemic, that we think are less important or are kind of been pushed to one side. So I'm just going to do a kind of brief reminder of some of the particular issues in prescribing for people with learning disability. All of my prescribing practices with adults, not with children. So again, it was great to hear from Mark some of the, you know, key things for children, and some of those are no different for the adults. You know, very, very common things across the entire age range. So if we're thinking about mental health and learning disability, we've had a number of large studies. The one by Glasgow in particular was probably the most beneficial, the largest studied population that we've seen in terms of identifying mental health and learning disability. In this particular study actually did diagnostic assessments on every participant rather than just looking at what was in the files. And we can see there that the comparison of mental health issues in the learning disability population significantly greater than that in the general population. And I think the impact of the pandemic, you know, if we were to do a study kind of progressing through, you know, we'll see that even greater if we were to look at it now, and potentially with a long-lasting impact, I think, given that people with learning disabilities struggle to kind of overcome some of the societal impacts and the change that's required. So I think we'll see that kind of long-lasting. And this particular study highlighted at the time, I mean, this is going back some notes to 2007, the standard processes for making a diagnosis in relation to a mental illness missed about 50% of the actual cases that were existing. And that's because of the way in which people were applying diagnostic criteria. For children and young people, I think Mark will have covered this probably in more detail than me, but again, the differential is even greater. So you're looking at predominantly, you know, around between 30 and 50% of children and young people with learning disability have a coexisting mental illness, depending on which studies you look at and what the parameters were, versus around 8% in the general population. And interestingly, that of all of the children accessing mental health services, those with learning disabilities accounted for 14% of those. And you can see it goes across all of the ICD-10 diagnostic categories. So not particularly, you know, specific elements of that. So some of the reasons link with some of these factors, really. Diagnostic overshadowing, and we're seeing that significantly. Certainly in the early part of the pandemic, we saw a lot of attributing people's behavioural change to the restrictions in place, to the kind of general factors that were going on. So again, we've had some impact on delayed diagnosis because of diagnostic overshadowing with the physical health situation and the pandemic situation. Whereas historically, we've seen it as a result of everybody attributing the person's presentation to their learning disability rather than considering a coexisting mental illness. there's a need to adjust diagnostic indicators, and that's difficult for some of our colleagues who work in mainstream services if they've not had experience with people with learning disability before. And again, you know, kind of interpreting the behaviour, what that behaviour might mean and how that might link with a diagnostic indicator. For some individuals, signs and symptoms are a lot more subtle. People are unable in some circumstances to describe their symptoms, you know, that inability to communicate the change that's happening in their bodies. Sometimes they're not noticeable until they've progressed to quite a severe level. So they might have been seen as just like the person's just a little bit off colour, or, you know, not quite themselves. And it's only when it becomes a more significant presentation of behavioural distress that people are really picking it up and considering it as a symptom of mental illness. So just as an example, the Diagnostic Manual for Intellectual Disability helps for what are those adjustments needed to standard diagnostic processes. And I've just pulled out a few examples here in relation to depression, just to give you that notion of how we might look at something slightly differently in the learning disability population. And I'm not going to read through it all. You can kind of see there that we've been looking at some of those behavioural indicators, not necessarily a person's kind of verbal report of a change in how they feel or how they are living their life, that we're actually looking for what can people see, what can carers see, what concrete changes might there have been, and how might that link with a diagnostic indicator. So as such, there's reasonable adjustments needed, particularly in that assessment stage. I'm not sure, I missed the beginning of Mark's presentation, I'm very sorry about that, but I'm not sure if you picked up that, again, we've had quite a few people referred through as new individuals requiring diagnosis during this pandemic. And some of that is difficult for us to assess in this context. But we're having to look at those broader indicators of signs and symptoms, as I've kind of just described, looking at the diagnostic manuals. We're having to think about our communication methods with them, given that we've got these altered communication styles as a result of the restrictions and the risk assessments around direct contact. And then we've got some of the adjustments that are needed to consider the person's cognitive ability, their impact of learning disability on their ability to understand and to communicate. There's a greater need in our field for corroboration of information. So even where we've got people with learning disability who can describe what changes may have occurred, we need to understand the timeline for that, the context for that. And quite often it's those abstract concepts that people with learning disability really struggle with. You know, when you get down into how long has this been occurring for? Has it been in the last month? And the need to kind of use some kind of concrete anchors for the individuals to try and work out, have they had a birthday recently? Did they have a particular event recently? And that's more difficult in a pandemic where people are not having holidays or parties or going to the theatre, those real concrete experiences that allow us to anchor, has it been before then or since then that you've been experiencing these things? And we need to make sure we're using information from multiple sources. So quite often we rely on historical information within the files, speaking to other people that are supporting the individual. And again, as a result of the pandemic, we've had reduced contact from things like day service providers, respite care providers, personal assistants and people that do leisure activities, etc. So that's reducing the amount of information that we've got available to assist us with that assessment. So we do think about what information we can get beforehand. We know that family carers in particular, but also people with learning disabilities, get sick of answering the same questions with different people and giving the same information over. So the way in which we work is to try and gather as much of that information as we can and just clarify it as part of the assessment appointment or the follow-up appointment. Information in relation to approaching the assessment, again, is really important. What adjustments might be needed in terms of the location, the methods of communication, who should be supporting the individual. And that's really important during this pandemic phase. So, you know, as we've been using virtual means, thinking about, does the person need somebody else to assist them? Do they prefer to have everybody's face in the screen or just the one person who's speaking? You know, do they want their own camera on or do they not? Do they prefer telephone to video? I mean, there's a whole range of things that have kind of come into that consideration of the how to approach a consultation, how to approach an assessment, that's affected some of the practicalities of the appointment offer. So whereas previously we'd only think about the physical location and who's going to be in the room and out the room and whether it needs to be a home visit or if it can be in a clinic setting, we've now got all of these other factors to think about as well. And that means that we need to think about how do we get that corroborative history and current corroboration of signs and symptoms as well. And certainly in my practice, it's led to a number of different consultations. So where I might have managed a kind of clinic appointment with different people coming in and out at different points, I'm now having to set up multiple appointments virtually in order to get that information and think about, you know, do I need to get a member of the team to go out and be at the house with the individual to assist with the technology? Do I need to do that myself? You know, as Mark said, do I physically need to see the person to pick up some of those other issues that might be related to symptomology or might be related to side effects of medication or about context? You know, we get a heck of a lot of information from being in the same room as somebody and even more from doing a home visit. But yet all of those information flows are being interrupted at the minute during this kind of pandemic phase. So explaining what's going to be happening, we've had to adjust some of that as well. And some of it, we don't know exactly how it's going to progress. We might get a technology issue, you know, the platforms might fail. You know, there's been a few times where I've had to revert from a video platform to a phone platform because somebody's connectivity's gone. You know, and that ability to be really flexible in your style and be open to kind of considering options is really important, but might also increase the frequency of follow-up or the shortness of period between your contact and a further follow-up, depending on whether you're able to get everything there. And expect the unexpected. I think Mark was a classic example of that. You know, he'd planned for everything, but still there was some printing needed. And that goes for the people that we're contacting. You know, at the end of the day, we are contacting into people's homes, into people's lives. So whether they're living with family, whether they're living in fully supported settings. I've been on calls with an individual where co-tenants have come into the call and wanted to chat socially. And these are individuals with learning disability. You can't kind of dismiss them and push them away immediately. So, you know, do think about, you know, what else could happen and kind of be responsive to that on the back of what's going on. So in terms of that general communication, I think I've covered most of this of thinking about preparing ahead of time, thinking particularly about communication. Communication is interrupted if we're doing a face contact by face masks, by all of those PPE, by the distance that we have to have. It's impacted virtually in terms of our ability to read people's body language. We can't see what's going on for people. Yes, we might be able to see their face, but we can't see what else is going on. We can't see if there's a level of irritability coming or if our questions are particularly problematic for people. If they're not showing it in their facial features, but you know, there's something else going on in the background. Equally, we can't pick up when people are being kind of coached or coerced by people that might not be within the visual field. So, you know, those kinds of things you can pick up in person, but not necessarily always in terms of that virtual approach. And we need to kind of make sure we're using those carers really, really well. So we, as in any kind of setting where people have paid carers, with family carers, I think it's a little bit different because they've got that continuity of information. But where it's paid carers, you know, checking how long has that person actually worked there? Or is this organisation in business continuity and they're working on agency staff in entirety because they've lost their entire paid workforce who were off shielding or self-isolated, you know, kind of understanding the impact of how those kind of staffing changes are impacting on how people understand the person, how they're collecting information and how they're then kind of sharing that information across. So we do need to think about appropriate prescribing. I agree with everything that Mark highlighted there. We've got various different groups, some where them and their infrastructure are requesting or needing more prescription, those where actually things are going okay. We haven't had any that are coming in saying, can you please reduce the medication? In fairness, as a result of the pandemic, there are some where medications were occurring previously in terms of reduction plans, and we've had to make a decision of, do we stall or do we continue? And a lot of that depends on the person's infrastructure. And in that respect, we're having to think even more so about that mantra of start low and go slow, you know, whether it's an initiation or whether it's a decision to reduce. Each step change needs to be a small step change, and we need to take our time about it for individuals and closely monitor that therapeutic effect, and ensure we're keeping some sort of track. Mark mentioned Stomp and Stamp, which is the initiative for children. There's an initiative for adults as well, which is Stomp, predominantly around trying to reduce the prescribing in those where it's being used for behavioural management. And what we're seeing from the Stomp initiative in adults is that there are somewhere, as we are approaching medication reductions, we're seeing symptomology of mental illness that was previously undiagnosed. So we're then having to look into, you know, appropriate diagnosis, appropriate prescribing, in the same way that the children's programme is. And I've just included in the slide deck, bearing in mind that I'm aware the slide deck will be shared subsequently. This is the algorithm in the adult Stomp documents in relation to considering those medication reductions and working your way through to, are you looking at a discontinuation plan, or are you looking at a rationalisation or retaining medication as it is? So mantra to take away for anybody with a learning disability is the start low, go slow. And then finally, just some of the specific things around COVID. I've covered a number of these as I've been going along. We have had a mixed response to new technologies. We've had people who really don't like it. There are a number of people who are still doing visiting. And social distancing is really difficult for some people with learning disabilities. So that is a bit of a risk. You know, we've had to rag rate those who need visits, as Mark was describing, and equally we've had to rag rate our staff in terms of who are the right people to do visiting where that visits are necessary. We do need to think about the burden on family carers in particularly. You know, they've got a reduced access to respite, an increased day-to-day caring burden. And that in itself is causing some difficulties, and we've had to give some additional support. We've had to increase some people's support packages. We've had to introduce some personal assistant time into support individuals. And the kind of pandemic situation has limited some of our creativity. So a lot of what we work on with in the learning disability context is a lot of those non-pharmacological interventions and trying to be creative about multiple elements. And the pandemic has really limited that and that ability to think about those non-pharmacological interventions. And as a result, some people have ended up with much more medication.
Chris, have you
that's my last one. Yeah, that's my last one. So,
okay.
You know, there's been a range of things that have been going on. I think carers, we really need to listen to carers and hear what they're saying, not just, you know, take it on face value, but look at, you know, what are the wider impacts for carers and what that might mean. As Mark said, we've had to compromise on some of our principles around prescribing in order to keep people at home and to keep people safe. So yeah, over to questions, and I'm also with you for the afternoon's group sessions as well.
Thank you so much, Chris. We have a question from Mina Paul, and I just need to sort out my reverb. Minu, could you ask your question to Chris, please?
Sorry, my internet's a bit poor, but the question I wanted to ask was, I'm a GP and I'm actually from Oxfordshire CCG, and the reason I'm joining this call today is because I wanted to learn a bit more about your observations during the pandemic. We're trying to improve the learning disability annual health checks in primary care, and we're struggling with it really. And I just wondered if you had any tips from communications with your colleagues where you worked that could help inform us on how we can improve in our area.
Yeah, so we've been really fortunate on our patch. The commissioning infrastructure has invested money to allow us to bring in nurses to support the annual health check process by doing a number of pre-check kind of questionnaires, gathering of information, etc. So that GP colleagues like yourselves and practice nurses can focus in on those elements that only they can do and that they need to do in order to finalise the annual health check. There has been sharing across the system on ways of kind of looking at the entire population and again rag rating and identifying those at greatest risk and therefore at greatest need of the annual health check, which for those of you not involved kind of looks at a whole system check of somebody with learning disability, recognising multiple underlying physical health factors that are often undiagnosed, but lead to a greater vulnerability, particularly during the pandemic phase. So the early deaths of people with learning disability, when we looked at the first 6 weeks of the pandemic, gave us some really shocking insights actually into the impact of COVID. And that there was a lot more susceptibility. For some, we knew that there were underlying physical health factors that made them more vulnerable. For others, those hadn't been identified, but yet they had died much quicker than others. So the annual health check is currently the way of trying to make sure we're identifying as much physical health need as we can. And that we're reviewing prescriptions as part of that. But as Mark said earlier on, we're trying to delay medication reductions because we don't want to prompt somebody going into behavioural distress or mental health crisis and then needing an admission, which puts them at greater risk. So all of us across the system are really balancing these benefits and risks even more so than pre-pandemic stages. And that's making clinical decision making quite difficult.
Thanks very much, Chris, and thanks for this great question, Nina. So in the interest of time, Chris, we've got a couple more questions for you, but we'll pause them until we have our group discussion, if that's okay. And we'll move on to Mark, who's going to talk about antidepressant withdrawal, what clinicians should know. And while Mark gets himself ready and gets his slides up on screen, I'll just introduce him. He's a training psychiatrist and a clinical research fellow at the University College London. He has an interest in rational prescribing in psychiatry, including de-prescribing, when and how to stop medications. Mark can be found on Twitter, and I think Andre's put his Twitter handle in to the chat. And I noticed, Mark, that you published something in the Daily Mail and you got thousands of shares, which was quite interesting. So it's obviously a very interesting topic. So have we got Mark's slides up yet?
Yes.
Yes.
Yeah. Is that all going through? Good. Okay. So I'll talk for a few minutes about antidepressant withdrawal and how to avoid it, but no conflicts of interest. So it's a little bit of a story, a little bit about the past, the present, and maybe where we should go. So for a long time, the official guidance on antidepressant withdrawal syndrome, in fact, until a couple of years ago, this is what it said in the NICE guidelines. Discontinuation symptoms are usually mild and self-limiting over about 1 week, but can be severe, particularly if the drug is stopped abruptly. And this description was actually based on the output of a consensus panel put together by Eli Lilly in the late 90s. They coined the euphemism discontinuation symptoms and distributed numerous papers with the description brief and mild, and that made its way into the NICE guidelines because it was so prevalent. In terms of the current NICE guidance on how to come off antidepressants and how to manage withdrawal symptoms, it currently recommends gradually reduce the dose, normally over a 4-week period, although some people may require longer periods, particularly with drugs with a shorter half-life. But this is not very precise. There's no guidance on how to reduce the dose, what gradually means, and what a longer period may entail. And it's not based on very much evidence at all. In fact, there was one study that showed that reducing by over 5 to 8 days caused 2 severe withdrawal effects, and the 4-week figure was just came up with by the committee by consensus. The consequence of this guidance has been that hundreds of thousands of people have gone to the internet to get advice on how to come off their antidepressants because they find the advice given by doctors causes them so much distress. So these are 2 commonly attended websites, Surviving Antidepressants and the Withdrawal Project. They get about 1 million hits a month, and one of them has about 300,000 different posts, and I'll summarize them for you. I've read a lot of them. The commonest story is, my GP or psychiatrist told me to stop taking my antidepressant over between 0 and 4 weeks. The effects were so horrendous that I had to go back on them. The GP told me there shouldn't be a problem with coming off them, so it must be my original condition coming back, diagnosed me with relapse, and informed me that I should be on this drug lifelong. But it felt different to my original condition, e.g. I had dizziness, brain zaps, or other symptoms. So I don't trust my doctor anymore. The advice on this website was more helpful than my doctor, and coming off much more slowly than they suggested has made this process much easier, although still not easy. Just last month, there was a paper published that found there were tens of thousands of people on Facebook groups getting advice on how to come off their antidepressant because doctors were unable to help them. 1 in 6 were from the UK, and these numbers are growing at about 30% a year. So just very briefly, the antidepressant withdrawal syndrome, it's a collection of physical and psychological symptoms that occur on stopping or reducing the dose of an antidepressant. It occurs because the changes to the brain caused by antidepressant use take time to resolve, and we're learning that that time is more like months and years rather than days in long-term use. The most common symptoms are dizziness, insomnia, impaired concentration, fatigue, headache, tremor, tachycardia, nightmares. There are emotional symptoms, depressed mood, irritability, anxiety, and panic attacks, even in people that have never had those before starting the medication. And there are also some quite distinctive sensory symptoms, what people describe as electric shock sensations in the head, like zaps, often on moving their eyes or in their limbs. There are also lots of gut symptoms because there are a lot of serotonin receptors in the gut. There's also an increase in suicide attempts in the 2 weeks after stopping an antidepressant. So it can be a very difficult time for people. Until a couple of years ago, no one had looked at how common, severe or long-lasting these withdrawal symptoms can be. And the first systematic review to do this was done in 2019. And what they found was that looking at the small number of trials that exist, 14 trials, that looked at how common withdrawal symptoms were, about half of patients, 56%, experienced withdrawal symptoms. That didn't matter whether they looked at randomized controlled trials, mostly done by drug companies, observational studies done by doctors, or online surveys, if, for example, one done by the Royal College of Psychiatrists. They all found approximately half of people experienced these symptoms. Analysing the data in their study, you can also see that the longer you're on an antidepressant, the more likely you are to have withdrawal symptoms. So taking paroxetine, if you're only on it for a few months, about a quarter of people will have withdrawal symptoms. By the time you're on it for more than 3 years, more like 2/3 of people will have withdrawal symptoms. And that's also true for fluoxetine and for escitalopram. That's also true for how severe the symptoms are. So the line with the boxes is what percentage of people report having either moderately severe or severe withdrawal symptoms. And it depends on how long they've been on the treatment. So if you've only been on it for a few months, only a quarter of people will say the symptoms were severe, but by the time you're on it for more than 3 years, you have about a 50% chance of experiencing withdrawal symptoms that are severe. The duration of how long antidepressant withdrawal symptoms last for is not as well studied. There again does appear to be a relationship between how long you've been on the antidepressants and how long those symptoms last. And that makes sense because the longer you're on the drug, the more it affects your brain, the longer it takes for your brain to go back to its normal state. And you can see that people who are on the drugs for just a few months have weeks of withdrawal symptoms, but once you're on it for years, then the average person has withdrawal symptoms that last for months and sometimes for more than a year, although some of these studies are done on selected populations. So based on these studies and others, the Royal College of Psychiatrists updated its guidance a couple of years ago to say that patients should be informed of the potential in some people for severe and long-lasting withdrawal symptoms on and after stopping antidepressants. And so when an antidepressant is being considered, this should be part of informed consent for a patient. NICE also updated its guidance on antidepressant withdrawal symptoms. It now says, explain that whilst the withdrawal symptoms which arise when stopping or reducing antidepressants can be mild and self-limiting, there is substantial variation in people's experience, with symptoms lasting much longer, sometimes months or years, and being more severe for some patients. So one important issue is misdiagnosing antidepressant withdrawal effects as relapse of the underlying condition. It's reported to occur often, but it hasn't been studied in detail. Withdrawal symptoms can include anxiety, depressed mood, insomnia, and appetite changes, even in people with no underlying mental health condition, e.g. those prescribed for migraine. So just because these symptoms arise doesn't mean that it's necessarily relapse. It's easy to confuse with relapse of depression or anxiety, especially when we've been taught for so many years that withdrawal effects are only mild and brief. So if we see severe or long-lasting effects, it makes sense to think that that is relapse. But we have better information now. Clues to distinguish withdrawal from relapse. Often it has a quick onset, days after stopping an antidepressant, rather than the weeks or months you might expect for relapse. One slight trick is that fluoxetine has a very long half-life of several weeks, and so its withdrawal effects can be quite delayed. There are also specific symptoms that mark out withdrawal from relapse, things like dizziness or electric shock sensations in the head, or really any other symptoms that were not present in baseline. So if someone when they're depressed becomes very lethargic and loses their appetite, but when they withdraw from a medication, they become very anxious and have trouble sleeping, then it's more likely that that is withdrawal effects rather than that their underlying condition has somehow morphed. And the other element that's a clue is if you restart the antidepressant, the withdrawal symptoms go away reasonably quickly, sometimes in hours or a day or two, especially if it's restarted soon after withdrawal symptoms occur. So the Royal College of Psychiatrists launched a guidance on stopping antidepressants at the end of last year. I'll spend the last few minutes talking about that guidance. It recommends patients who have been on antidepressants for more than a few weeks taper off over months or longer. And they suggest going down to very small doses, less than 1 milligram for most medications, before stopping. And they recommend going down in smaller and smaller size reductions. Some of those recommendations might sound a little bit strange, so I'm going to try and explain where they came from. So a couple of years ago, we published a paper in the Lancashire Psychiatry looking at brain imaging of antidepressants. Hopefully you won't all fall asleep when I put a graph up, but it'll make sense reasonably quickly. This is a graph that shows the relationship between citalopram, common SSRI, and its effect on the brain, in particular its effect on the serotonin transporter, which is the major target of antidepressants in the brain. I've just lost my mouse, I can't put it on it. But this curve, you can see, goes up very steeply at small doses. So every extra milligram of medication you add when you're at 0 milligrams adds a lot of effect in terms of its effect on the brain. But once you get to 20 milligrams, every extra milligram of medication has less and less effect on the brain. And that's a common characteristic of medications, that small doses have very large effects. And that can help us work out a rational way to taper antidepressants. So looking at this graph, we can make sense of what happens if we recommend what I would call a linear reduction. So the sort of reduction that I used to recommend to patients, say reducing from 20 milligrams of citalopram to 15 milligrams to 10 to 5 to 0. It makes sense, it seems intuitively evenly spaced. But in reality, if you look at the effect on the brain, the reduction from 20 milligrams to 15 milligrams has a very small effect, only 3% percentage points change in the effect on the brain. From 15 to 10, a little bit more. If you look at the y-axis, again, I can't get my mouse to function. And if you go from 10 to 5, a slightly larger effect on the brain. But when you go from 5 milligrams to 0 milligrams, you can see that there's a very large effect on the brain. So actually about 15 times larger than the reduction from 20 milligrams to 15 milligrams. And this seems to correspond to the increasingly severe withdrawal symptoms patients report as they get to lower total doses. So these are two representative comments that I hear a lot of. It was the last few beads that were the hardest to come off when talking about antidepressants, or a story like this. I started on 75 milligrams of venlafaxine. I had no problem tapering down till I got to 15 milligrams. Every time I would go down another 5 milligrams, I was so dizzy and had so many zaps, I couldn't handle it. I had to go down by 1 milligram at a time. I still can't get below 5 milligrams. You can hear that things are getting more difficult as they get down to lower doses. And so this graph also allows us to see what a solution might be. Rather than reducing antidepressants by even amounts of dose, we can reduce them by even amounts of effect on the brain. So I'm just getting my mouse to work. And so you can see that if we reduce by amounts that reduce the effect on the brain by even amounts, in this case, 20 percentage points of serotonin transporter activity, you can see that this gives us doses on the x-axis that are reasonably strange. So going down from 19 milligrams to 5.4 to 2.3 to 0.8 will actually give us even changes in effect on the brain. And you could describe these doses as hyperbolically reducing doses. And the first, and that's just because it's following this curve, which is in the shape of a hyperbola. And what you can see is the final dose before stopping will need to be very small so that this final reduction is not larger than the reductions before that people have been able to tolerate. So you can see going from 20 milligrams down to 5 is actually the same size reduction as going down from 0.8 milligrams to 0. So to make that a little bit simpler in practice, halving doses is approximately equal to reducing according to that hyperbolic pattern. So going down from 20 milligrams to 10 to 5 to 2.5, 1.25, 0.6, and then 0 is approximately evenly spaced in terms of effect on the brain. In actual fact, in my experience and lots of other people's experience, going down even by these big jumps is too fast, it's too big. And so what many people say that they can tolerate is reducing by 10% of the last dose every month. And that still fits into this hyperbolic pattern. There's just many more lines, many more steps in this process. And that's where the Royal College of Psychiatrists guidance came from. So it recommends individualizing the rate of reduction to what is tolerated by the patient. And everybody will be different depending on their medication, how long they've been on it, and probably something about their brains. If withdrawal symptoms become too severe, then the reduction should be halted or the dose increased a bit until symptoms resolve, and then reduction should proceed at a slower pace. And many patients can only reduce their dose at 10% of the most recent dose per month, which means reductions get smaller and smaller. So reducing by, I'll show you some examples. So these are the two examples given in the Royal College of Psychiatrists guidelines. This is, I would consider this to be a relatively quick reduction of citalopram. This, in my experience, only a small proportion of patients can tolerate this. This involves halving the dose every fortnight or month. And you can see it goes down to 20 to 10 to 5 to 2.5 to 1.25 to 0.60. One thing worth noting is the smallest available tablet for citalopram is 10 milligrams. So once you get down to 5 milligrams, you'll need to split tablets in half or start using a liquid preparation, which is available in England. And certainly by the time you're down to 1.25 milligrams, it's extremely hard to make that by splitting tablets, and to get an accurate amount, you'll need to use a liquid preparation. I'll give you an example of a slower regime. So this is, paroxetine is a particularly hard drug to reduce, and many people will only be able to reduce it by 10% a month. And so that might involve starting at 40 milligrams and going down by 4 milligrams. These numbers have been rounded to make them a bit simpler. Going down by 4 milligrams at a time for a while, then down 3 milligrams at a time when you're at 30 milligrams. And by the time you're around 20 milligrams, reducing by 2 milligrams each time. And in fact, here there's another 29 steps until you're down to very low doses like 0.6 milligrams before stopping. And because these doses are intermediate between what tablets are available, you'll need to start using liquids right off. And so people will do things like using a 30 milligram tablet and a small amount of liquid, and working that out for each step. So using a combination of tablets and liquid. And some people will need to go slower than this. In fact, this regime with about 30 steps separated by a fortnight or a month probably will take about 2 or 3 years for people to come off medication. And I've certainly heard for people coming off paroxetine that it can take them 5 or 6 or 7 years because the withdrawal symptoms are so unpleasant, they've got to go down by very small amounts. And for example, for paroxetine, liquids are available. If I had to give one message to prescribers, it's to give formulations of medications to patients that allows them to taper easily, like liquids, because a lot of patients are currently forced at home to grind up tablets, to dissolve them, to go to all sorts of kind of mad lengths in order to make up these doses. So doctors can help them out, or prescribers, by giving them access to these doses of just about times at the end. I'm just going about to finish up. So tablet cutters, to make these small doses, tablet cutters can be used at the start, but at the very small doses, liquid preparations will be required. There's also something called tapering strips available from a Dutch pharmacy, but actually lots of medications are available in liquid form, as you can check on the BNF, or in oral drops, or in dispersible tablets. And that's me. Happy to take any questions or answer any emails.
Thank you, Mark. That was just terrific. 3 fantastic presentations. We do have some questions, and we'll just move, I think, straight into a discussion across the 3 presentations. And perhaps, I don't know if we have Mark the medic. Is he back online, or have we lost him? There he is. You had a question that cut across all 3 topics for today, and it was around microdosing for children with learning disability. Do you want to just pad that out a bit for Mark H to respond to?
Yeah, Mark. So my query was, so I use microdosing within children with learning disabilities and autism with quite a few of my medications, but I can get effects with fluoxetine, for instance, on very severe anxiety. Sometimes there's doses as low as 1 or 2 milligrams. With regards to the sort of saturation of the receptors, do you know of any science that might actually account for that?
I mean, looking at the graph, again, yes, very small doses have significant effects. So something like 1 milligram of fluoxetine has about half the effect of 80 milligrams. So, or maybe a third the effect of 80 milligrams. So yes, I think under that rubric, small doses do seem to have much more significant effects than we've previously thought. And so I think if you're seeing responses, it certainly makes sense to use the lowest possible dose, because that's the way you're going to minimize adverse effects. So if you're seeing it working, that makes sense.
Okay, thank you for that. A couple of notes before we move on to the next question.
And even,
sorry. Go, Mark.
So I was just going to do a supplementary question. Even at the other end, where I've got to say 20 milligrams of fluoxetine, microdose increases at 20 milligrams, even though they're proportionally very small, have still produced positive effects?
I can't support that one with neuroscience. That sounds more like a psychological effect to me, because small doses, once you're at commonly,
And which would surprise me based upon, I'm not sure if you can hear me.
Yeah. So, yeah.
Okay, sorry to cut across you, Mark, there. Just a couple of notes. I noticed a couple of people were taking photos of the slides throughout the presentations. We are sharing the slide sets with you all on the webinar today afterwards, so you don't need to worry about that. And just to reinforce the hashtag, which is prescribing pandemic, which there's an interesting Twitter discussion about the nuances of what that phrase actually means. That's where we can bring together the questions both in the room and beyond the room. So we have another question, which actually is probably a general question, I think, across all three speakers, which is from beyond the room, Mark H. And it's about how much we can learn about micro reductions of drug therapies from other medications that are being used, you know, some sharing of the learning. And then a supplementary question to that is whether there's interest in producing more home reduction kits rather than patients doing a do-it-yourself job.
Yeah, great questions. So actually, I think a lot of tapering has come out of psychiatric medication. So I'm not sure there's a lot to learn from other medications. I think they've learned from us a bit. For example, I think the only tapering that I'm aware of is from steroids in mainstream medicine, and they tend to do things quite quickly. And I think some of their practices might be influenced a bit by the slower tapering now being recommended in psychiatry. I think it's worth acknowledging that a lot of this has been developed by patients off their own bat. So for the last 30 years, patients have been finding it hard to come off antidepressants and benzodiazepines. The first reports of withdrawal symptoms from antidepressants came out in the early 1990s, just 3 years after Prozac was released on the market. So patients have been doing it by themselves, in their kitchens, in their bathrooms, discussing with each other online for 3 or 4 decades now. And they really are the experts. And a lot of the ideas that have been put into the Royal College of Psychiatrists guidance has come from patient experts. So I think that's another really great, we can learn from patients a great deal. In terms of reduction kits, yeah, so some of the things that I've heard patients do, to me seems it's quite ridiculous that they're pushed to these to do these things. They grind tablets, they dissolve them, they buy jeweler's scales off Amazon to measure out these tiny doses because they find that too large a reduction causes them trouble. And in fact, it was a quite brilliant biologist in Holland who himself was coming off venlafaxine, who's invented something called tapering strips that I'm pretty sure are available in the UK. They've got a website, and they have basically made it easy for you. They've made it into, so you can reduce citalopram by 0.5 milligrams each time, and you can order whatever kind of doses you like for lots of different medications, and that's quite a useful initiative. And they have been talking about trialling that in the NHS, and I know that the Royal College of Psychiatrists wrote to the Health Minister to request a trial of that in GP practices, because it would certainly make life easier for doctors and for patients, because this is it is a complicated process. I think you can see that from the presentation. It's not easy. It involves a lot of work to get off these medications, and I think that should also play into how readily we prescribe these medications, knowing that we're going to produce difficulties coming off it in the long run.
Thank you, Mark. Okay, next question is for Chris, and it's another cross-cutting question, and it's about STOMP, which is stopping the over-medication of children and young people with learning disability, autism, or both. That's not obviously for you, Chris, that's for me to remind me what STOMP is, and for anyone out there who's not familiar with that acronym. And it's about the how the pandemic has compromised efforts potentially in STOMP. And the question is around, is that being measured? And if so, how, or monitored in some way? And also Mark had a follow-up question around STOMP, which we'll come to in a minute.
So I think from my personal experience, myself and my fellow nurse prescribers, as well as the psychiatrists who work in our service, we are seeing that the actual STOMP values and principles are being compromised currently, that we are limited in what we can do. We haven't completely forgotten them, and there are some people, you know, as Mark said, and I've said, some people are doing really well in the pandemic. They actually like the restriction and being at home all the time, and we have been able to progress things for that small number, but it is a small number. I'm not aware of anybody actually monitoring it either, you know, in a kind of organised manner across a local or a national level. So I think we will only come to learn the impact over time. And at the minute, it's not an area that I'm aware of that anybody's specifically looking at. So I think it's down to us as individual prescribers to keep an eye on that, and to not forget that the minute that we can get back to looking at those reduction processes, to actually get back to that, you know, and as Mark has said, you've got to go slow and you've got to use it, you know, really low, small dose reductions, just to make sure that we don't throw people into that kind of withdrawal response.
Yeah, it's a nice linked point, isn't it? The go slow one by both of you. I'll just turn to Andre. Is there anything, Andre, from beyond the room that the speakers could respond to before I go to the next question that I've got?
No, all the questions I've posted, I think, from YouTube and from Twitter. So I think we're up to date with all of that. Thank you.
Okay, so the next question is for Mark, and it feels like COVID's here to stay for a while, unfortunately, despite our best efforts. And I wonder, you talked about creative solutions at the end of your presentation. How sustainable do you think some of those are, you know, given that we're looking at this situation for probably many months, if not a year or so?
Some of the solutions are absolutely sustainable. Use of video conferencing, use of telephone, for instance, whereas the bits where we have had to really reduce the number of staff present in buildings or access to our buildings and face-to-face, that won't be sustainable in the longer term. We are coming up with, this isn't just about prescribing, but alternatives to, say, assessments in autism using some online alternatives. And those give us some information, but they're not quite as good as the original face-to-face assessments. So that will be a real challenge for us going forward. And some things just won't be sustainable. But use of telephone, use of video conferencing absolutely are sustainable for certain people. But every so often we are going to have to do face-to-faces to keep things safe.
Mm-hmm. And Chris, did you want to respond to that question about sustainability of some of the new ways that you've had to work with people with learning disabilities?
I guess just to add to what Mark said, I think the challenge for us as clinicians beyond the pandemic is to be really clear about what's the threshold and the criteria for it being safe to do online consultations with people as opposed to direct face-to-face. So at the minute, we're kind of doing that assessment, but in a pandemic context, and beyond the pandemic, with a context shift, we need to rethink what are the parameters then, because we've got to be careful that we don't end up doing so much online that we're losing quality information that we gain from that interaction from people in their home context. It can give us so much information to inform our diagnosis, treatment plans, our prescribing decisions. You can't underestimate that. So we will need to think carefully around, what we do and how we do it post-pandemic.
Yeah, thank you very much. I was very struck by, in your presentation, the sort of information flows and the interruption to those and how much impact that can have on clinical and prescribing decisions. Okay, so I'm just checking the, here we go. It's from Mark. Question for Mark then finally was around, Mark, it was very striking in your presentation, the gap between the numbers of studies about the efficacy of antidepressants, lots, and then those that explore withdrawal, not many. How do we address that? There's such an uneven picture in terms of evidence on which to make prescribing decisions, yeah?
Yeah, it certainly is. So there's been about 1,000 studies done on starting antidepressants, but only about 24 on stopping them. And that's largely because of the priorities of the funders of those studies, which are mostly funded by drug companies. And so it's had a big influence on the guidelines that we have, because the high quality studies are done by big companies about starting antidepressants. It has a very big influence on guidelines, whereas because the studies on stopping antidepressants are smaller, they are not the sort of things that are imported into NICE guidelines. So I think we need to redress that by funding studies on how to stop antidepressants and how to stop other psychiatric drugs in order to make up for the deficit. We can't just accept that the evidence base has been created by for-profit corporations. These are affecting all of us. We're all patients and as well as being professionals, and so we need a better evidence base. We also need to listen to patients. If patients are telling us again and again having trouble coming off antidepressants or other psychiatric drugs, I think we need to take them seriously rather than saying, well, it's not in the randomized controlled trial that I've just seen. Having said that, there are placebo-controlled randomized controlled trials showing withdrawal effects. They've been around for 20 years. So there's also different focus on what aspects of the literature we focus on. So I think we need to start paying attention to what trouble people have with these drugs and how to come off them, and also doing studies on the best way to help people avoid these troubles.
Mm-hmm. Mm-hmm. Okay, thanks very much, Mark. Quite a meta level to finish on, but a really important one, I think. So we reached the end of our morning nearly. I just wondered, one thing I want to do is thank all the presenters for fantastic, nuanced, rich presentations, which hopefully will give the people in the room some thought for later on today, and those beyond the room. I hope they've helped in terms of prescribing decisions and practice. I would like us to show our appreciation for our speakers. So if everybody could just either put your camera on or even just wave. It's quite hard to do a sort of, yes, thank you very much. Put your camera on and wave to show your appreciation. You can also use the hand clapping emoji in Zoom. Thank you so much, speakers. You've been fantastic this morning. And we've welcomed the pandemic and working from home interruptions as part and parcel of how we do business these days. So for those of you that are staying for the afternoon, you now get a lunch break. But before you go, we just want to make a couple of announcements. And Andre is going to share on his screen